Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's March 2019 issue. There are 4 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice is an original article entitled A Modern Primer on Light Chain Amyloidosis in 592 patients with mass spectrometry verified typing. This paper is authored by Dr. Eli Mukhtar and colleagues from the divisions of Hematology and Nephrology and Hypertension at Mayo Clinic in Rochester, Minnesota. Amyloidosis is a life-threatening disease characterized by extracellular deposition of amyloid material in tissues and organs. These deposits are composed of organized fibrils that resist proteolysis, and while all amyloid deposits have similar fibrillar structure, they differ in the precursor protein that promotes amyloid formation. There are currently 36 known proteins that cause systemic or localized amyloidosis. Thus, from a classification as well as a clinical standpoint, it is necessary to correctly type the amyloid deposits because both therapy and prognosis are type-specific, and most therapies seek to reduce the extent of amyloid precursor protein formation. For much of the history of amyloidosis, amyloid typing was largely based on circumstantial evidence due to technical difficulties in typing. If there was a monoclonal protein, a patient was classified as having light chain AL, previously known as primary amyloidosis. If there was a family history, mutational analysis of DNA from peripheral blood mononuclear cells was examined for mutations in the known genes that may underlie hereditary amyloidosis. If there was an inflammatory condition, AA, previously known as secondary amyloidosis, was suspected. In the elderly without a monoclonal protein, age-related amyloidosis, previously called senile amyloidosis, was the diagnosis. Basing the typing of amyloidosis on inference may lead to misdiagnosis. For example, a monoclonal gammopathy is reported in 20 to 25% of patients with wild-type transthyretin amyloidosis, as well as in other non-AL subtypes. Immunofluorescence of renal amyloid, immunohistochemical analysis, and immunoglobed electron microscopy of tissue amyloid was subsequently used, employing commercial antibodies against amyloid precursor proteins. In specialized centers and in conjunction with clinical data, immunohistochemical analysis has a sensitivity that is greater than 90% for accurate typing. However, immunohistochemical analyses have yielded false positive, false negative, and equivocal results. In the modern era, the most accurate typing method for amyloidosis is a proteomic-based approach using mass spectrometry. This method is characterized by high sensitivity and specificity and is considered the gold standard for amyloid typing. It also allows identification of rare types of amyloidosis for which commercial antibodies for immunohistochemistry may not be available. Since 2008, mass spectrometry typing has been a routine practice at Mayo Clinic. There is substantial literature regarding the characteristics and prognosis of patients from earlier periods in which accurate diagnosis was limited by the techniques then available. In the present study, Mukhtar et al. Described the characteristics of a large population of patients in the modern era with biopsy-proven, mass spectrometry confirmed AL amyloidosis, diagnosed from January 2008 through August 2015. In this study, the median patient age at diagnosis was 63 years. The heart was the most commonly involved organ at 76% of patients, followed by the kidney at 53%, nerves 24%, and the liver at 18%. 34% of patients had isolated organ involvement, involving principally the heart at 19%, followed by the kidney at 9%. 41% of patients had two involved organs, and 25% had more than two involved organs. Patients with isolated cardiac involvement had similar cardiac dysfunction compared with those with non-isolated cardiac amyloidosis. Isolated renal involvement was associated with increased proteinuria and a higher estimated glomerular filtration rate as compared with non-isolated renal amyloidosis. Serum and urine immunofixation electrophoresis results were positive in 80% and 88% of patients respectively, with 94% of patients having at least one positive immunofixation electrophoresis result, serum or urine. The serum-free light chain ratio was abnormal in 91% of patients. When all monoclonal protein studies were combined, only one patient had normal results. The 1-year and 5-year survival rates were 65% and 46% respectively. Survival of patients with cardiac amyloidosis was not influenced by the number of involved organs, thereby emphasizing the prognostic significance of cardiac involvement. This study also provides additional relevant data regarding patient characteristics, responses to therapy, and outcomes of accurately typed patients. The authors conclude that when mass spectrometry is used to definitively type amyloid, only a fraction of a percent of patients with AL amyloidosis will have negative monoclonal protein studies, quite unlike historical reports. The change in patient population characteristics over the years probably reflects changes in the disease recognition and diagnosis and more accurate typing in the modern era. 2 of our 3 highlighted articles address the health benefits of yoga, the first demonstrating the antihypertensive effects of yoga, the second describing injuries that may be caused by the practice of yoga. Yoga originated in India thousands of years ago and was introduced to the West in the 19th century. Since then, its popularity and its practice have substantially grown. Studies in the United States have reported that the 12-month prevalence of yoga practiced increased from 3.8% in 2004 to 8.9% in 2016, with a lifetime prevalence of 13.2%. The benefits of yoga on flexibility, strength, and balance are widely known, and there is substantial and increasing interest that yoga may confer salutary effects for a number of diseases. Traditional yoga seeks to align the body and mind, and its basic modern form utilizes 3 elements, namely physical postures, breathing techniques, and meditation and mental relaxation. The beneficial effects of yoga on hypertension are examined in the original article entitled Yoga as an Antihypertensive Lifestyle Therapy, a Systematic Review and Meta-Analysis, authored by Dr. Yin Wu and colleagues from the Department of Kinesiology, Institute for Collaboration on Health, Intervention and Policy, at the University of Connecticut, Storrs, Connecticut, and the Department of Physical Therapy at the University of Pittsburgh School of Health and Rehabilitation Sciences, Pittsburgh, Pennsylvania. Based on recent studies such as the SPRINT trial, systemic hypertension is now redefined to a lower blood pressure threshold of 130 millimeters of mercury for systolic blood pressure and 80 millimeters of mercury for diastolic blood pressure. Accordingly, some 46% of U.S. adults exhibit systemic hypertension. The 2017 American College of Cardiology and the American Heart Association guidelines emphasized the importance of lifestyle interventions such as regular exercise for the treatment of hypertension. A lifestyle intervention that may reduce blood pressure is yoga, as shown by several studies and 3 prior meta-analyses of these studies. The results from these studies, while encouraging, are inconsistent and display considerable variability in the antihypertensive effects. The main factor that may underline the inconsistent results is that all 3 previous meta-analyses only performed subgroup analysis because of the relatively small sample sizes. The primary purpose of the present meta-analysis of Wu et al. Was to provide more precise estimates of the antihypertensive effects of yoga by including the largest sample size to date, thereby enabling meta-regression analyses to examine the effects of multiple moderators simultaneously and identifying which combination of yoga elements yielded the greatest blood pressure lowering effects. Wu et al. Systematically searched 6 electronic databases from inception through June 2018 for articles published in English language journals on trials of yoga interventions that involved adult participants, reported pre-intervention and post-intervention blood pressure, and had a non-exercise, non-diet control group. This search yielded 49 qualifying control trials involving 3,514 trial participants. The results demonstrate that on average, the participants were middle-aged, overweight adults with systolic and diastolic blood pressures of 129 and 81 millimeters of mercury. Yoga was practiced approximately 4.8 sessions per week for 59 minutes per session for 13 weeks. On average, yoga elicited moderate reductions in systolic and diastolic blood pressures of 5 and 4 millimeters of mercury compared to controls. Controlling for publication bias and methodological study quality, when yoga was practiced 3 sessions per week among subjects with hypertension, yoga interventions that included breathing techniques and meditation and mental relaxation elicited reductions in systolic and diastolic blood pressures of 11 and 6 millimeters of mercury respectively, compared with those that did not, the latter exhibiting reductions of 6 and 3 millimeters of mercury respectively. The authors conclude that yoga is a viable antihypertensive lifestyle therapy that produces the greatest reduction in blood pressure when breathing techniques and meditation and mental relaxation are included. Yoga may thus be considered a lifestyle intervention that confers salutary effects in the management of systemic hypertension. The second highlight article underscores injuries that may be sustained by yoga. It is an original article entitled Soft Tissue and Bony Injuries Attributed to the Practice of Yoga, a Biomechanical Analysis and Implications for Management. It is authored by Dr. Melody Lee and colleagues from the Department of Physical Medicine and Rehabilitation at Mayo Clinic in Rochester, Minnesota, and the Department of Physical Medicine and Rehabilitation at Virginia Commonwealth University, Richmond, Virginia. Because yoga improves flexibility, strength, and balance, many healthcare professionals have encouraged the practice of yoga as a safe exercise for patients at different levels of health. However, several reports have described injuries resulting from yoga, ranging from mild muscle strains to bony fractures. For osteoporotic and osteopenic patients in particular, the reports of bony injuries raise concerns that warrant further investigation. With some exceptions, the current literature does not appear to recommend sufficient caution or accommodations for yoga in patients with impaired bone integrity. Additionally, little or no guidance is available regarding potentially dangerous maneuvers. The primary aim of this study was to identify patients who were injured while practicing yoga and to determine the specific poses that caused their injuries. Injury was defined as musculoskeletal pain or discomfort severe enough for a patient to seek physician evaluation. The secondary aim of this study was to identify poses that should be avoided based on these results and kinesiologic principles, particularly for patients with underlying osteopenia or osteoporosis. The authors retrospectively reviewed the medical records of patients with injuries that were primarily caused by yoga. Patients were seen from January 2006 through December 2018. Injuries were categorized into three groups: soft tissue injury, axial non-bony injury, and bony injury. Patients underwent evaluation and were counseled to modify exercise activity. 89 patients were identified for inclusion of the study. Within the soft tissue group, 74% had mechanical myofascial pain due to overuse, while rotator cuff injury was seen in 7%. In the axial group, exacerbation of pain was observed in 52% of patients with degenerative joint disease and in 38% of patients with facet arthropathy. Radiculopathy was observed in 6% of patients. In the axial group, exacerbation of pain was observed in 52% of patients with degenerative joint disease and in 38% of patients with facet arthropathy. Radiculopathy was observed in 6% of patients. Within the bony injury category, kyphoscoliosis was seen on imaging in 17%. Spondylolisthesis was present in 17%. Anterior wedging was seen in 18%, and compression fractures in 15% of patients. The poses that were most commonly identified as causing the injuries involved hyperflexion and hyperextension of the spine. Finally, the authors correlated the kinesiologic effects of such exercises on specific musculoskeletal structures. The authors conclude that while yoga potentially has many benefits, it is by no means a completely benign form of exercise, and caution is warranted when counseling patients on its practice. Care must be taken when performing positions with extreme spinal flexion and extension. Patients with osteopenia or osteoporosis may have higher risks of compression fractures or deformities and would benefit from avoided extreme spinal flexion. Physicians should consider such risks when discussing yoga as an exercise for patients. The third highlight is an original article entitled Safety of Influenza Vaccination Administered During Hospitalization. It is authored by Dr. Sarah Tartoff and colleagues from the Department of Research and Evaluation at Kaiser Permanente, Southern California, and Southern California Permanente Medical Group in Pasadena, California. Yearly vaccination against influenza is advised for all persons aged 6 months and older, and for whom there are no contraindications. Patient-provider interaction during hospitalization affords an opportunity for influenza vaccination of patients. The Centers for Disease Control and Prevention currently recommend that hospitalized patients who are eligible to receive influenza vaccine be vaccinated before discharge. Moreover, encounters in the inpatient setting provide an opportunity to reach those at highest risks for complications from influenza, such as older patients and those with comorbidities. This clinical care strategy effectively provides preventative care, and inpatient immunization is regarded as a quality metric by the National Committee for Quality Assurance, the Joint Commission, and the Centers for Medicare and Medicaid Services. Yet, despite these recommendations, the rates of influenza immunization among hospitalized patients are low. The decisions against such vaccination may reflect views held by the physician or the patient. Namely, there may be the concern that vaccination during hospitalization may incur vaccine-associated adverse events which complicate care and cause increased healthcare utilization. In the present study, Tartov and colleagues assessed influenza vaccination during hospitalization and evaluated whether such vaccination during hospitalization increased healthcare utilization, fever, and evaluations for infection following discharge. The authors undertook a retrospective cohort analysis that included patients aged 6 months or older hospitalized in a Kaiser Permanente Southern California facility with admission and discharge dates between September and March of the following calendar year, from 2011 to 2014. All influenza vaccinations administered during the period of August to April for influenza seasons 2011 to 2012, 2012 to 2013, and 2013 to 2014 were identified. The authors compared the risk of outcomes of interest between those who received influenza vaccination during their hospitalization versus those who were never vaccinated that season or were vaccinated at other times. Outcomes of interest included rates of outpatient and emergency department visits, readmissions, fever, and clinical laboratory evaluations for infection, including urine, blood, and wound culture, and a complete blood cell count in the 7 days following discharge. Data analyzed involved approximately 300,000 hospitalizations among more than 250,000 patients. In adjusted analyses, the data demonstrated no evidence for increased risk of readmissions, outpatient visits, fever, and clinical evaluations for infection among those vaccinated during hospitalization as compared with those who were never vaccinated or were vaccinated at other times. The authors conclude that these findings provide reassurance regarding the safety of influenza vaccination during hospitalization. Patient interaction with a healthcare provider during hospitalization potentially affords an opportunity to vaccinate against influenza, one that is supported by current recommendations and one that serves strategies aimed at reducing the morbidity and mortality associated with influenza. You can access these highlights and editor's choice articles free of charge during the entire month of March when you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org. You will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study and practice. Currently, we are featuring Dr. Nanette Wenger, a distinguished professor from Emory University in Atlanta, Georgia. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.